Thank you for that kind introduction, and thanks for inviting me to be here. I'm going to have some competition from next door, so if you can't hear me, please just raise your hand. I'm not I'm not used to having a loud noise next to me, but we'll see what we can do. 2 years ago, my daughter, 2 years after she graduated from high school, my daughter went to a wedding of a couple of her classmates, and the best man was also a friend of hers from her class. After the wedding, a group of friends went over to their house, to the bride and groom's house, and partied some more and spent the night. The next morning, when the groom was, everybody was kind of getting together for breakfast, and the best man didn't show up, so he went over into the bedroom and found the best man in the bed, dead. He had drunk alcohol and taken Librium as well. And this tragedy repeats itself hundreds of times, as you probably know, in this country. And so what I'm going to talk a little bit about is how to recognize prescription drug use and maybe how to take some steps to stop it. Learning objectives for today are to identify the most misused prescription drugs, and I'm going to be talking about 3 classifications of drugs: opioids, stimulants, and sedative hypnotics, because those are the 3 most misused classes of drugs. Understand who's most likely to misuse prescription drugs, and what are the potential health consequences of misuse. Understand when opioids should be used to treat chronic pain, along with alternate approaches. Be familiar with the diagnostic criteria for drug use disorders, and identify medications and other approaches to treating drug use disorders. I just wanted to start out with a few terms. Misuse is the intentional use of a drug for the purpose of achieving a desirable psychological or physiological effect, instead of how it was prescribed for the person. Addiction is a chronic relapsing disorder characterized by loss of control over use, chronic craving and drug seeking, and use despite negative consequences like those shown. It is characterized by long-lasting changes in the brain. Like other chronic diseases, addiction often involves cycles of relapse and remission. In the 2015 National Survey on Drug Use and Health, 6.5 million Americans older than age 12 had illegally used prescription medications in the previous month. That rate was second only to marijuana and greater than past month use of cocaine, heroin, and hallucinogens combined. More people died from drug overdoses in 2014 than any other year on record. And more than 3 out of 5 drug overdose deaths involved an opioid. Deaths from drug overdoses are up among both men and women, all ages, and adults and all adults. In 2003, we started using opioids. In 2003, 4,200 people a day began using opioids. In fact, sadly, in 2009, car crash deaths were overcome by deaths from overdose. So how did this happen? Well, it was a process. Opioids are the most potent pain relievers. They act by attaching to specific proteins called opioid receptors, found on nerve cells in the brain and spinal cord, as well as the GI tract and other body organs. When these drugs attach to their receptors, they reduce the perception of pain and produce a sense of well-being. These effects are mediated by specific subtypes of opioid receptors, and there are 3 of them, mu, delta, and kappa, that are activated by naturally occurring opioid chemicals, which are called endorphins or enkephalins. The pleasure feelings happen because opioids activate brain regions involved in reward. Opioids are prescribed mainly for acute pain from surgery, or when you have your tooth out, or you have an infection, and other forms of acute pain. They're also prescribed for cancer pain, and occasionally they're prescribed for coughs and diarrhea. But more and more, they've been prescribed for chronic pain. So what is chronic pain? Chronic pain is the largest reason people see medical providers. And 19% of all U.S. adults complain of chronic pain. Chronic pain is pain that persists past the normal time of tissue healing, which is about 3 months. So pain that persists or is intermittent, it could be intermittent or it could be steady pain, but anything like that that persists and is not caused by cancer is called chronic pain. The main reasons for chronic pain, as you know, are problems with the back, neck, hips, joints. Autoimmune diseases like rheumatoid arthritis can cause inflammation of the joints. And diabetic neuropathy is a big reason people have chronic pain, and also fibromyalgia. So those are some of the major causes. This slide shows you some opioid pain relievers that have been heavily prescribed for chronic pain. And this includes a wide variety of compounds: oxycodone, morphine, hydromorphone, oxymorphone, hydrocodone, fentanyl, meperidine, codeine, methadone, and buprenorphine. They can be straight extracts from the opium poppy, or they can be extracts that have been chemically modified, or completely synthetic compounds. Opioids can be short-acting like morphine sulfate, extended release, which are short-acting compounds that are formulated to be absorbed slowly by the body, so they can be taken at larger, longer intervals. And an example of that is Zohydro or OxyContin. And long-acting like methadone or buprenorphine. People who misuse pills may crush these pills so they can be snorted or injected, as you probably know. And these pills typically contain higher doses because they're meant to be taken over a long period of time. So they're very dangerous when people try to dissolve them and put them into solution and inject them. At the lower left, you see the difference between a tamper-resistant pill and one that is more easily dissolved for injection. Purdue Pharmaceuticals introduced the time-release version of oxycodone, OxyContin, in 1996, and direct marketed both to patients as well as physicians, while playing down safety and addiction concerns. In 2001, the Joint Commission that accredits and certifies nearly 21,000 healthcare organizations began promoting programs that called pain the fifth vital sign. So when you go to a doctor, you get your vital signs taken, right? Your pulse, your blood pressure, your temperature, your respiration. So now the Joint Commission is saying, hey, let's just ask everybody if they have pain. Well, you can imagine what an impact that had. And this is a quote from one of my fellow physicians. Patients want the most potent pain relievers, so they started to demand opioids. I want OxyContin. I heard that's really good. And the problem is, when you take a blood pressure, it's an objective measure. But when you ask a patient, what's your pain level from a scale of 0 to 10? They might say 100 or 1,000. Well, what does that mean? Some patients come in with a broken bone and they say 5, and the other ones have a toothache or an earache or something. 2,000. So it's really difficult to sort that out. It makes big problems for physicians. But as a result of all these campaigns, the number of prescriptions written for opioid pain relievers soared. In 2012, healthcare providers wrote 259 million prescriptions for opioid pain relievers. And that's enough for every adult American in the United States to get a whole week's worth of it. That's a lot of pills. OxyContin became one of the most misused prescription drugs in history, and it is estimated to cause 100,000 drug-related deaths worldwide per year. And as you can see, emergency department admissions went up, treatment admissions for substance abuse went up, and overdose deaths more than tripled in the past 20 years. In 2007, Purdue was fined $600 million by the FDA for making misleading statements about the abuse potential of OxyContin. Attorneys for a number of state governments sued the drug companies that developed these products, alleging they deceived physicians and patients by exaggerating the effectiveness and withholding information regarding the dangerous addictive effects of drugs. In 2010, they bought back the old formulation and created that new formulation that I showed you in the picture earlier. The medical community responded by more closely scrutinizing doctors who were top prescribers, and the DEA continuously attempts to shut down the online illegal sales of controlled substances. A June 2016 MedPage Today article reporting on the American Medical Association's annual meeting in Chicago quoted Dr. James Millam of Illinois. And he said, "Just as we now know the earth is not flat, we know that pain is not a vital sign. Let's remove that from the lexicon. Whether the Joint Commission says they didn't ever say pain should be a fifth vital sign, we must do whatever we can, whatever we can do to no longer include it. Let's just get rid of the whole concept to try to move on." Another effort in the struggle to reduce overdose deaths was the development of prescription drug monitoring programs, or PDMPs. How many of you have heard of PDMP? How many of your treatment centers that you refer to use the PDMP? Do you have access? Do any of you have access? You have access. PDMPs are databases that collect electronically transmitted prescription data and allow prescribers and dispensers to check their active patients' prescription history. PDMPs have been instituted in D.C. and all states except Missouri, which I believe is now enacting legislation to start its own. Increasingly, states are mandating participation before a provider writes a prescription for controlled substances. Access to the database, though, may be strictly limited. That is, in some states, Medicaid officials may have access to the database, but private health plan case managers, pharmacy managers, fraud control, and medical review officers do not. How do you get access?
I'm a prescriber, so I have access. Montana mandates reporting. The only agency that's not cooperating with that right now is the VA administration in Montana, but otherwise it's all there.
So Montana mandates it?
Yes.
Okay. So one thing you can do is you can check with your provider and make sure they're checking to make sure that the people that you see aren't going to various sources and getting lots and lots of different prescriptions for controlled substances. Well, there are some unintended consequences, and one of them was that the supply of pills such as OxyContin plummeted, and therefore the price really went up, as you can see, whereas heroin is only $10 a bag. So other studies have shown that most people who just switched to heroin had previously taken pills. So it looks like a lot more heroin users are on board because they can't get the pills that they need for their addiction problems. So why aren't opioids a good way to treat chronic pain? Since 1999, opioid overdose deaths have increased 265% among men and 400% among women. 1 in 4 patients prescribed an opioid for the first time progresses to long-term prescriptions. Tolerance and withdrawal refers to the adjustment the body makes as it attempts to adapt to the continued and frequent use of a substance. And it applies not only to opioids, but to other drugs such as alcohol. This adjustment is called maintaining homeostatic balance. Tolerance occurs when people need to increase the amount of a substance to achieve the same desired effect. In other words, it is when someone experiences less of an effect using the same dose as they usually do. The desired effect might be a high, or it might be with relief from withdrawal symptoms. People experience tolerance differently. Specific drugs will vary in terms of how quickly tolerance develops and the dose needed. Withdrawal is the body's response to the abrupt cessation of a drug once the body has developed tolerance to it. With repeated administration of opioid drugs, the production of endogenous or internally produced opioids is inhibited, which accounts in part for the symptoms of withdrawal. But opioids also, in addition to making you feel good and taking your pain away, they produce drowsiness, mental confusion, nausea, constipation, and depending on the amount of drug taken, depressed respirations. Some people take opioids with drugs such as alcohol or tranquilizers, an especially dangerous combination, leading to overdose. Other users have switched from prescription opiates to heroin, as I just mentioned, as a result of availability and lower price. But because of the variable purity and other chemicals and drugs mixed with heroin on the black market, this also increases the risk of overdose. Opioids also change the brain's wiring and chemistry, making abstinence difficult, and causes constipation, decreased sex hormones like testosterone, slows tissue healing, and worsens sleep apnea. Does anyone know what hyperalgesia is? Well, this is, you do? Would you like to share? No? Okay. There have been a few articles written recently about hyperalgesia, but in some cases, and it's still being studied, opiates actually increase a sensitivity to pain. So people take higher and higher and higher doses of opioids. Their pain doesn't go away, but if you back off and withdraw the opioids, their pain actually gets better. Opioids should not be taken with alcohol, benzos, sleep aids, especially a drug called Soma. And it shouldn't be taken with those with impaired kidney or liver function. They place the user at risk for falls as well as vehicular crashes. Since an increasing number of women of childbearing years have been prescribed opioids, this has led to an increased number of newborns who are physically dependent on opioids. Subsequently, neonatal abstinence syndrome is on the rise. This syndrome may occur when a pregnant woman takes drugs such as heroin, codeine, Oxycontin, methadone, or buprenorphine. These substances pass through the placenta and the baby becomes dependent on the drug along with the mother. Evidence for the long-term effectiveness of opioids for treating chronic pain is not there. The consensus by experts is that, in general, opioids are not appropriate drugs to treat moderately severe chronic pain. They simply have too many side effects. The risk of addiction is too high, and over the long term, they have not proven to be effective. The best practice is to follow a stepped approach for easing pain. In this method, lower intensity interventions are used first. Treatment intensity increases step by step if lower intensity interventions fail or don't have the adequate effect. Self-care recommendations for low back pain, for example, include staying active, not just lying in bed, but getting up and moving around, educating the patient about the condition and the fact that it does typically get better, and using at-home approaches to reduce pain, like some people like hot packs, some people prefer cold. over-the-counter medications, and there are other medications that are non-addictive the doctor can prescribe, and exercise, whatever works for that person. This involves the concept of self-discovery, basically knowing yourself and knowing how you can help yourself get better. Other effective methods help a person cope with pain, such as distraction, progressive relaxation, meditation, guided imagery. It's also important to address other concerns that contribute to pain. And as you probably know, people with chronic pain can be very depressed, and treatment of that depression may actually help treat the chronic pain. Unfortunately, sometimes these efforts don't work, and there are pain clinics all around the country who can take these complex cases and really try to add a combination of medications and exercises and other therapies. Frequently there's injections and sometimes surgery to really help with the serious chronic pain. Is there a pain center here in Billings? Does anyone know? Yeah, it might be useful to find out whether there is one, because if your clients complain of pain and feel like they need opiates, they really need to be managed by a group that really knows what they're doing with looking at pain and all the ways to approach it.
You know, I'm from Great Falls, and they do have doctors that work in pain management, and I'm also a candidate for chronic pain. So what I see happening a lot of times is that I do release to the physician to discuss how they're being monitored, if there's any other alternative pain management plans that they're being recommended for. And I don't get a return call from the doctor back. And there's really, I think, a lack of trust with working with a treatment provider. And so it's kind of hard because, you know, to question or to try to intrude on someone's medical you know, their medical well-being and say, these are doing you harm. Of course, we educate about opiates and things of that nature, but you know, it's kind of like when you left messages from the doctor, you kind of get worn out continuing to try to engage the doctor to work with you, because a lot of times, you know, even if you caution some of the stuff that you're telling us about, as far as know your body's limitations when you're under the influence of opiates, you have a tendency to push your limits past and create more pain and create more problems with addiction.
It's a very complicated, problematic issue. And when 19% of all Americans have some sort of chronic pain, it seems like this is something that really needs our attention and the medical community's attention.
Right, and so I just don't know how to work through those barriers with doctors to get them to kind of feel more comfortable working with treatment providers, so we could kind of work together in combination so we reduce the number of overdoses, or and even kind of help create kind of a balance of medication plus, you know, a plan for exercise and a regimen of that nature, more so than just relying on the pills.
Well, you know, keep educating people, and hopefully those things are going to resolve. Try to bring people together as much as possible to talk about a case instead of having all this fragmented care that we see across the country. Grace, a 32-year-old woman, is involved in a motor crash 6 months ago. She was prescribed OxyContin for chronic pain, but it didn't really help that much. So she was prescribed higher and higher doses. She started taking more pills and running out of pills early. So my question to you is she addicted to opioids? And what are the symptoms of opioid or any drug addiction?
Tolerance.
Tolerance.
Withdrawal.
Taking more than prescribed.
Actually, this is a sign that there may be a problem. It isn't one of the criteria that we use to define a drug use disorder, but it's certainly an important piece. Any other suggestions for how we would find out what we would need to know about her to know if she had a drug use disorder?
Well, her daily activities, have they been curtailed? Have they, is she not doing the things she used to do as a result of being
Life functioning.
exactly?
Yeah, and one of the criteria is that it's whether you have harm caused by those drugs, such as social problems, legal problems, but you keep taking it despite those.
Intense mood changes?
Well, this would probably fall under the category of using a drug, spending a lot of time getting the drug, using the drug, or recovering from its effects. So basically, if it's causing you to not be yourself, that's one of the criteria. Any other?
Well, motor vehicle crash 6 months ago, and then chronic pain. How is that defined? 6 months is
Right.
that chronic? How is that
Right,
still?
yes. Chronic pain is defined as any pain that lasts more than what we would assume the body can heal. And usually healing takes about three months. So her pain persisted for 6 months, and therefore she was diagnosed with chronic, not cancer pain.
In that context, is she doing the other things that her providers are recommending? For example, physical therapy, occupational therapy. Is she doing other things in addition to taking the medication if all she's doing is taking meds and not following the other treatment recommendations?
That's a really good point, because a lot of people, they don't really want to do the work, they just want to take a pill. So, it's really important to find out those things when they're seen. To find out, well, are you taking the Tylenol? Are you getting up and walking every day? Are you,
And not doing the things that she's not supposed to do.
Yeah, exactly. Any other comments?
Well, I don't know that this is the case, but I mean, she's got a ton of pills in front of her. But a lot of women, postpartum depression, and if they've had a surgical intervention in the, a C-section, they're prescribed pain. She's got a coexisting problem with her depression. She was depressed before she delivered, maybe.
Yes. Well, it's true that depression is one of the warning signs for someone's probability of becoming addicted if they get on opiates. Comorbid disorders, other psychiatric disorders, really put people at risk for having a drug use disorder. Any other?
She's ingesting the medication in a different way rather than orally, if she's to snort it or, shoot it up instead of
Right.
taking it the way it was prescribed.
Yes, and that's another sign of aberrant behavior that, and I'll be going into that a little bit in a minute.
I've had, this has been a problem in my family with one of my family members. And I'm an addictions counselor, but whenever Auntie comes to our house, we have to hide everything. We've had interventions on her, and she in fact has been charged in court for writing prescriptions because she worked for a dental office. She stole prescriptions, but it's still an issue. And trying to get her to, we've attempted interventions with her, and it's failed. So she will come unannounced to the empty house. So if you anticipate she's coming, you have to hide all your medication.
It might be good for you to get one of those medicine cabinets that locks.
Well, the thing is that you can't speak with her because her denial level is so high, and she's been doing it for so many years. Now she's getting to the point where all of her methods of gaining medication are running out fast. And we're going to have critical mass pretty soon.
It's important to keep after her. I know it's really tough. I have a family member who has substance abuse problems as well, and it's a huge challenge. but you have to just keep trying. Okay, so the DSM-5 no longer uses the terms drug abuse and drug dependence. There used to be 2 diagnoses. Now it's only 1. It's called substance use disorder. And it's defined as mild, moderate, or severe. And it's determined by how many of these 11 criteria are met by the individual. And they include drug taken in larger amounts or more than intended, or they said, oh, I'm only going to, do this one day, and then they end up going into a binge. They can't cut down or control their use. Great deal of time to obtain the drug, use it, or recover from its effects. Craving, neglected obligations, harms relationships, giving up important activities that they used to do. They used to have a hobby, or they used to go fishing or whatever, but they don't do that anymore. They just stay home. Use in dangerous situations, and that includes riding a boat when you're high or drunk, or driving a car, or getting up on a ladder. Use despite health, psychological, or legal problems caused by use, and of course tolerance and drug withdrawal. But remember that tolerance and withdrawal doesn't mean for sure someone has an addiction disorder. They don't necessarily have a drug use disorder. There are lots of people who get prescribed codeine or Oxycontin or something after they have a tooth pulled or they have surgery. They take it for a certain amount of time. Then their body adjusts to it and they're physically addicted to it, but not psychologically. So in that situation, the doctor just decreases the doses gradually until they can get better. And sometimes it's hard to get off, but without that psychological need, it's not considered a drug use disorder. How are we doing on time? This is a summary of the actions taken when managing people who are considered for opiate therapy. One, you first of all try all the other options first. Don't jump into opiate therapy right away. Second is giving them a trial of a short-acting opiate like morphine instead of an extended release. Make sure that they sign informed consent so that they know the risks and benefits of what they're getting into, because it's very important for them to be educated. Setting goals and then reassess the goals. And then there's an exit strategy if the opioids don't work, because in a lot of cases they're not going to work very well. So cutting back and decreasing the opioids and trying something different is another strategy. Convincing data has shown that high doses, which are 100 to 120 morphine equivalents, are very dangerous and really put the person at high risk for an overdose. So it's very important. I mean, if you have clients who are taking medications, kind of try to figure out how much they're taking, and remind them that this is a level that's really critical. And they may feel like they need more and more and more. They may also have some behavioral health issues like PTSD or depression that you really need to get a handle on, so that you can prevent that dose from going up so high. This is the Portney and Payne's aberrant behavior scale, but there's a whole list of things that some of them you mentioned. That if the patient on opioids is doing any of these things, you got to consider seriously that they have a drug use disorder. So, these are, they're pretty obvious too. Obtaining prescription drugs from non-medical sources, losing prescriptions. I don't tell you how many times somebody came in and said, "Oh, my dog, I accidentally flushed him down the toilet." Lots of really interesting excuses. But also, and someone mentioned too, deteriorating function due to drug use. So, and sometimes family members don't really see it that clearly until it gets really bad.
It's interpreted as pain that's causing the decrease.
Yeah, yeah. So these are some of the things to look out for. And identifying that aberrant behavior is done best by using a number of different tools. And one of them, a few of them are here. Does anyone use screening instruments such as this in your practice? I see some heads nodding. It's really useful to use a questionnaire and then, keep using it as people come in every once in a while, see whether things are changing. And, of course, in drug court, people aren't necessarily going to be the most honest. I've done some studies showing that they're not very honest. But in some cases, when you build rapport over time, you can get people to be pretty honest because, after all, it's their lives that are at stake. Okay, so now I'm going to ask, what are the big 4 risks for someone who's taking opiates to develop a drug use disorder? Risk factors. What's number 1? I'm just saying the risk factors for developing a drug use disorder if you're given an opiate. Number 1 is if they have any other substance use disorder. So if they have a history of alcohol dependence, that's a big red flag. Comorbid disorders, such as depression, PTSD, other psychiatric illnesses, they're at very high risk. The younger the age, the higher the risk. And along with the substance use disorders, family history of substance use disorder is also another big risk factor. These are risk factors for an opioid overdose. So the behavioral risk factors are being discharged from a place where they weren't allowed to have any drugs, so their tolerance is going to be very low. People on methadone or buprenorphine, as I mentioned, the danger of the high dose prescription, greater than 100 milligrams morphine equivalent. And obviously a history of non-medical opiate use. And the medical risk factors are a current or past respiratory illness, HIV, history of alcohol abuse, and concurrent use of benzodiazepines. So these are the symptoms of, how many of you have seen someone who has had an opiate overdose? Quite a few. So you know the symptoms. People are nodding, they're incoherent, sometimes sleeping, sometimes snoring, limp, sometimes cold and clammy. But primarily the major issue is, are they breathing? Are they blue? It's obviously very life-threatening. Unless you have naloxone. Naloxone is really a near miracle drug that has been around for a long time, but is only now gaining the widespread respect and dissemination that it deserves. Naloxone has reversed more than 10,000 overdose cases between 1996 and 2010. For many years, it was available only as an injectable. When I was a student, med student years ago, we only had the injectable form, and we use it plenty. People brought in, and it's amazing. They're half dead, and you give an intravenous shot of naloxone, and they wake up. It's unbelievable. But now the FDA has approved a nasal spray. How many of you have heard of the nasal spray? Okay, it's FDA approved. A lot of people, you know, we would encourage them to carry naloxone, even EMTs, police officers, people like that. They don't want to stick a needle in someone. You know, that's just too much. It's too you know, scary. But this, you just put it up to their nose and do a squirt. It's got a measured dose. Wait 3 minutes. If they don't wake up, give them another dose, and you can keep doing that. The beauty of this drug, it has no other effects. There is no other medical uses for this drug. The only negative effect is it puts the person into immediate withdrawal, and they're not happy. They're very unhappy. However, it saves their lives. So who should carry naloxone? A lot of people should carry it. Police officers should carry it. If you have a relative, you should have some. Also, well, of course, EMT people have it. It says here, anyone using opioids not under medical supervision, but I've never really heard of anybody who self-administered naloxone because they thought they were going to overdose. I don't know. Maybe that is a little bit far-fetched. I'm not sure. So you can read that list. There are a number of states that have passed laws, like Good Samaritan laws, so that people who give naloxone are, you know, they're protected from being arrested themselves for being users, or if something bad happens, the person dies, then they can't get sued, that type of thing. Does anyone know if Montana has any of these laws? Yes?
Is naloxone over the counter?
No, it's a prescription drug.
Well, that's kind of dumb then, because that makes it really tough for people to obtain.
Well, yeah, but there are, some states are passing laws that pharmacists can give it out, and doctors should be easily they should be prescribing it as well.
So how do police officers get it if it's by prescription only?
Well, there are laws passed that allow for police to have it and distribute it. So maybe you have a physician who would prescribe it for use by police officers. But you know, these I don't know. I'm not sure what all the legal issues are, but I know that there are states where police officers carry it, and I think there are states where people can go to a pharmacy and say they have a loved one who has this problem, and they can get it. According to, tried to look it up, according to this thing called the Shatterproof Advocacy Center, anybody heard of that? As of August 2014, Montana had no current naloxone or Good Samaritan laws. So it would be really great if Montana could be nudged a little bit to kind of get this going, if they haven't already. Addiction, as you know, is a chronic relapsing disease. It involves cycles of, you know, people do okay for a while, and then they have a relapse, and then they have a remission. Crisis intervention is often needed, and those interventions that you were talking about, they're very important. And for a lot of people, they can turn things around, especially when you've got a hammer over their head. You know, the wife saying, well, okay, you get into treatment or I'm going to divorce you, or the court saying you're going to go to jail. Things like that sometimes really help. And medication is something that should also be considered. So now I'm going to talk a little bit about medication-assisted treatment. Medication-assisted treatment is the gold standard for treating opioid addiction. Without MAT, up to 95% of patients can relapse. The most effective drugs to treat opioid dependence are methadone, which is sold as Dolafine and Methadose, and buprenorphine, sold as Suboxone or Zubsolv. These are among the drugs classified as opioids, so treatment with these drugs is called opioid replacement therapy. Because methadone and buprenorphine are opioids, some people think, especially people that I've come into contact with in jails and things, they're saying, hey, you're just giving drugs to drug addicts. But, you know, that really is not true, because if it's taken as prescribed, it blocks the high that you could get if you do take other opioids. And, really importantly, it stops the person from going through withdrawal. A lot of people who have been, and remember I said, and this is being found for other drugs, like methamphetamine, it changes your brain chemistry, it changes the pathways in the brain and things. So people who've been on opioids for a while, their brains don't function normally, and they just don't feel normal unless they have an opiate on board. So methadone or buprenorphine can just make them feel normal. It doesn't make them high, it just makes them feel normal, okay. It's not to say that those drugs aren't misused, because they are. It has saved so many lives and allowed so many people to have a normal life. And typically, these drugs are just prescribed on an ongoing basis, like giving blood pressure medication to someone. You have to take it pretty much the rest of your life. Buprenorphine is a methadone is an agonist, so it binds to the opioid receptor quite strongly. Buprenorphine also combines with the opioid receptor, but it's only a partial agonist. So the beauty of that is that buprenorphine has a ceiling effect, and it isn't as dangerous for overdose as methadone. The main downside of buprenorphine is that for people who need really high doses of methadone to feel normal, buprenorphine won't cut it. But for many, many people, buprenorphine is a really good drug. It's also used for detox, because a lot of people will say, I really just want to get off of this. So buprenorphine is a good medication for that as well.
Is the use of the latter more profound than methadone?
Profound meaning?
Well, is it going to be an effective tool in getting them clean totally?
If it can be, but most people in the addiction field recommend that people stay on buprenorphine, because withdrawal frequently lends itself to relapse.
Right away.
Yes?
So where does Vivitrol fit in?
Okay, I'm just going to talk about that now.
I'm a plant.
You're a plant. Okay. I actually was one of the investigators who studied Vivitrol for the treatment of alcohol dependence. And so I'm very familiar with the drug. It was recently FDA approved for the treatment of opiate dependence. And that's a little bit of a different story. Because alcohol has three reward pathways. One of them is the opioid receptor. And people who are addicted to opioids, that's the same receptor. So an antagonist like Vivitrol or oral naltrexone can help people not drink and help people not use drugs. In fact, that's how we figured out, or someone figured out, that people who are on naltrexone for heroin weren't drinking as much. So then FDA started thinking, well, maybe we got to see how it works for alcohol dependence. And it is FDA approved for the treatment of alcohol dependence. Naltrexone is an oral pill that you can take, that you need to take every day. Vivitrol is a deep intramuscular injection, and it lasts for 1 month. The beauty of Vivitrol is it works, almost immediately. And if you're monitoring whether someone is staying with treatment, you know whether they got the shot. So it's a lot easier to monitor. So that's a big advantage. The side effects can be nausea, depression, allergic reaction, and sometimes liver damage, but that's kind of rare. We always measure liver enzymes before we give Vivitrol. But what I've seen is the major problem is that it sometimes leaves a pretty big lump in your rear end. So every month you usually switch sides, and most people don't get that, but sometimes that happens. Some of the recent studies have shown that it decreases craving, and that would be a good thing if that were the case. I feel like that aspect of it needs to be studied a bit more. And the potential negatives, the downsides, are some people still have craving and want to get off of it, and they get off of it, and then if they go back to street opioids or pills, they can overdose because now their tolerance is going way down. So that's the negative side. How many of you have used or are promoting any of these therapies for? Okay, and how many of you are using Vivitrol? So what's been your experience been like?
For the most part, clients report that it helps as far as cravings, but I have had a client relapse while taking Vivitrol. So I mean, yeah, just one. Didn't do anything about the thoughts.
On what did they relapse? What did they relapse on?
Initially, he thought he could go gamble and have fun and not drink, and then he ended up drinking and doing it. But what he's reporting the next day when he called me from his P&P was that he didn't really feel like he had a hangover. He didn't really feel a lot of those effects, but he was blowing like a 0.2. So it took away some of the effects of being drunk.
Yeah, some of my patients one of my patients, he got his first shot, he came back for the next appointment, and I said, well, how's everything going? And he goes, well, after I got that shot, I went out and drank a couple of 6-packs. I said, well, why did you do that? He said, well, I wanted to see whether it worked. So yeah, they're a fun bunch. Okay, so any other questions about those?
So are there statistics right now out on buprenorphine as far as long-term adherence versus people quitting? I mean, people I still hear a lot of contradicting opinions with buprenorphine. Like, should they take it forever versus should you quit? If you weren't a long-term user.
Well, obviously it would be better if people aren't on medications. It's better for us if we don't need a blood pressure medication or whatever. And it has to be very individual. So if the person is happy, adjusted, has a good life, has a job, functioning well in society and everything, then why take them off of it? But in some cases, patients really want to go on. And I would say that a lot of it needs to be led by the patient's needs, the individual situation. And yes, people do relapse on methadone, they relapse on buprenorphine, and they relapse on Vivitrol. It's just part of the disease.
Is it expensive?
Buprenorphine? It is expensive. It's more expensive than methadone. Buprenorphine can be given by a physician in the doctor's office, whereas methadone can't be if it's to treat addictions. Methadone can only be dispensed at a methadone clinic. However, if the person is being treated for pain, they can get it in the doctor's office. Which, you go, what's going on here? But anyway, those are the laws. Buprenorphine is expensive. Vivitrol is also expensive. In many cases, insurance will pay for both buprenorphine and Vivitrol, and that's what you kind of have to hope. And for a while, Alkermes was giving the first shot of Vivitrol for free, and I don't know if that's going on still. Do you know? Anybody know?
There's rumors that there's a way to get it.
And well, it's so call Alkermes and find out, because it is very expensive. I've heard it's up to $600 a shot. On the other hand, people spend a lot of money on alcohol and other drugs, so it may be worth it.
What about Medicaid? I mean, you mentioned insurance, but
States regulate that, and so in some, you have to find out what Montana.
We have clients on the Vivitrol shot, and I got them hooked up with Medicaid expansion, and it pays for the shot in full.
Well, that's good.
So I don't know about other parts of the state, but we have a low-cost health clinic in Missoula, where if you have Medicaid, there's a $5 copay for naloxone.
Wow,
As
fantastic.
long as you have your prescriber is there. So we,
And that's the oral, the
the
pill?
shot,
The shot, okay.
or the oral, but
Okay.
in the treatment courts, it's just so much easier to monitor if they've received the
Well,
shot.
new compounds are being developed that exhibit novel properties as a result of their combined activity on two different opioid receptors, mu and delta. Preclinical studies show these compounds can induce strong analgesia or pain relief, but fail to produce tolerance or dependence. Researchers are also getting closer to developing a new generation of non-opioid-based medications for severe pain that would circumvent the brain reward pathways. So there's a lot of potential coming down the pipe. This includes compounds that work through a type of cannabinoid or marijuana receptor found primarily in the peripheral nervous system. NIDA is also exploring the use of non-medication strategies for management, such as new neurofeedback. So, strategies for drug courts probably should promote non-opioid treatment for chronic pain, refer for psychiatric assessment. In some cases, people have to go get a physical, but they don't get the psychiatric assessment that they really need. Use MATs in addition to counseling, limit those permitted opioid prescriptions to one prescriber and one dispenser. Encourage providers and dispensers to routinely consult the PDMP, and where legal, promote naloxone distribution. Also, there are take-back programs, so if you have opioids lying around, you know, somebody might, you're selling your house, sometimes people just go through open houses just to look in medicine cabinets and steal opioids. So, you know, those ought to be under lock and key. So, I'm going to switch now to stimulants. Stimulants accelerate brain activity and have a variety of legitimate medical uses. They can be synthetic, such as amphetamines, or they can be plant-based, such as cocaine. They're usually taken orally, snorted, or injected. They increase alertness, attention, and energy, as well as elevate blood pressure, heart rate, and respiration. They include a wide range of drugs that have historically been used to treat conditions such as obesity, attention deficit hyperactivity disorder, depression. One amphetamine-like drug, Vyvanse, is now FDA approved for the treatment of binge eating disorder. Like other prescription medications, they are diverted for use. And this is pretty remarkable, but this is an fMRI of someone without Adderall and then after Adderall, where the red indicates brain activity. Look at that. That's amazing. That whole brain is activated. The peak age at which people begin taking stimulants is from age 16 to 19 years. Females are more likely to misuse stimulants, particularly diet pills, than males, with the peak incidence at age 18. Twice that of their male counterparts. It is estimated that 5 to 10% of high school students, 5 to 35% of college students have taken amphetamines. In 2014, an estimated 913,000 people ages 12 and older had a stimulant use disorder because of cocaine use, and an estimated 476,000 people had a stimulant use disorder as a result of using other stimulants besides methamphetamine. How are the stimulants obtained? Well, studies have, basically they're surveys, and most people get them from, at least start out getting them from friends or relatives. Physicians, sometimes will prescribe. Illegal sources, very, very common. Sharing was the most common method of diversion among students, with 1/3 of students sharing their prescriptions and about 10% who sell them. Bill is a community college student. He works part-time at a local factory. He's been prescribed Ritalin for ADHD since high school. He gives meds to his fellow workers and begins selling meds. So, how many of you deal with stimulant abusers? Quite a few. And what about prescription doses? People act nervous or jittery, they have high energy, they have a dry mouth. Lots of times they lose weight, they can't sleep, they have stomach pains, other GI problems like diarrhea, headaches and dizziness, fast heart rate, dental problems, and fetal effects, because amphetamines can cause abortion and some birth defects. Withdrawal symptoms that occur after stopping or reducing use include fatigue, vivid and unpleasant dreams, sleep problems, increased appetite, or problems with their controlling their movements. These are some of the symptoms of overdose. It's very serious. It can be fatal. The person gets a very high body temperature. They can have seizures. They have hallucinations. They get paranoid. Sometimes act violently. It's a very nasty scenario. And chronic use can lead to heart and blood vessel problems. And people who use stimulants, they get sexually excited, and so they'll have unsafe sex. They may drink alcohol or take benzos or something to get to come down. They have trouble with managing their lives, and if they're operating a motor vehicle, obviously that's going to be a big problem. And of course, that's led to a lot of emergency department visits, so ED doctors need to know how to treat it. I was one of the investigators who studied about 3 different new drugs to see whether we could find something that would work with methamphetamine or with cocaine and other stimulant use disorder. Unfortunately, none of those trials panned out. What we did was we gave them the experimental drug or a placebo, and as well as cognitive behavioral therapy to see whether the pill made a difference. And unfortunately, in these national studies, it did not. So there is no FDA-approved medication to treat amphetamine abuse, which is desperately needed, and the FDA is desperately seeking something, but so far it hasn't happened.
Is that for amphetamine specifically, or breaking it down to, like, say, methamphetamine, because of all the different ways to cook, salt, that kind of stuff?
It's for
makes it difficult
some have been
match.
tried with methamphetamine, some other amphetamines. So no, there's just right now there's just not anything that's close to being FDA approved. Yes.
But there is one study using Vivitrol and methamphetamine that's published out of Stanford that does support the use of Vivitrol.
Really? Well, I haven't seen that. When was it published?
I'll get it for you.
Okay. All right. Sometimes you can try a brief intervention, and for some people it can make a huge difference. However, typically it's not enough, so you have to increase your intensity of your treatment from outpatient therapy, intensive outpatient, sometimes inpatient therapy. There are a couple of psychosocial treatments that work pretty well. One is cognitive behavioral therapy. Another one that is pretty promising is called contingency management therapy. So now I'm going to talk about the last classification, which are the sedative hypnotics. The class of sedative hypnotic drugs includes minor tranquilizers like Valium and Xanax, sleep aids like Lunesta, Ambien, and Sonata, and barbiturates like Seconal and Amytal. They slow down the brain's functions, cause drowsiness and sleepiness, and are used to reduce anxiety and induce sleep. They also reduce heart rate and breathing, sometimes to the point of death, like my daughter's friend. One of the most marked effects of sedatives is their potential for abuse and addiction. It doesn't take long before people become addicted to it. Intolerance develops very quickly. Common benzodiazepines include this whole list: Ativan, Cerax, Klonopin, Xanax, Valium, and Transine. And there are a lot of benzos that are also used for sleep, and these include Imavane, and some of them, and Ambien is a big one. Some of them are differently structured. They're somewhat related to the benzodiazepines and have some of the same side effects. The sedative category includes barbiturates. Commonly misused barbiturates are Seconal and Nembutal. And then there are some other ones that don't fit under some of these classifications, but they're also central nervous system depressants like Quaaludes, Placidil, and some of the rest of these medications. Sleep medications in particular are dangerous because people think of them as harmless. But long-term use can be problematic due to tolerance and the need for higher doses. Nearly 10% of those who reported past year non-medical use of tranquilizers or sedatives, that's 500,000 people in the United States, meet criteria for a drug use disorder. High-risk occupations are medicine, manufacturing, entertainment, professional sports, and also occupations that require a lot of travel over different time periods. It really disrupts people's sleep cycles. There are two types of people who misuse sedative hypnotics. One are just people who are typically poly-drug users, and they use the sedative hypnotic to come down from something like an amphetamine or methamphetamine or ecstasy or bath salts, something like that. And then there's another group of people, typically older women who are depressed, who use it and they unintentionally keep using it and get more and more and more, and then they become addicted. Almost 1 in 10 adults report misuse of sedatives sometime in their lifetime. And the prevalence of past year non-medical use of sedative hypnotics in the U.S. was 2.3%. So it's not a huge problem percentage-wise.
Where does amitriptyline fit in there? Just like sedative.
Well, amitriptyline is one of the antidepressants, and some of the antidepressants can cause sedation. Yeah. In fact, there are some antidepressants that are prescribed for people to help them sleep, but they're a completely different classification. So these are the risk factors for drug use disorder with sedative hypnotics. But the unwanted side effects are pretty big. There's tolerance and withdrawal, anxiety, aggression, restlessness, which is a paradoxical excitement syndrome that sometimes happens when people describe these. Hallucinations, change in personality, falls, traffic crashes, dizziness, memory problems. And a big problem is residual effects. Sedatives don't always wear off when they're supposed to, especially when taken in quantity during abuse. So an addicted person runs a risk of not being attentive enough to care for children, drive an automobile, or to succeed in work or school. Actually, one of my colleagues took an Ambien, and the next morning she got up to drive to work. And there was a red light, and there was a car stopped in front of her, and she saw the car, and she stopped, and hit the car in front of her. And the lady got out, and she said, "What's wrong? What's wrong with you?" She'd just taken an Ambien the night before. So, I mean, these residual effects can be...
There's a lot of documentation right now around Ambien and bizarre behaviors.
Yeah.
And people doing
Sleep
things
driving
that,
and stuff like that.
coming home with $300 worth of Walmart bags and waking up in the morning and having no idea where we were.
It's pretty scary. It's almost like an alcohol blackout. Sedative hypnotics pass through the placenta and may cause preterm birth, low birth weight, fetal death, and birth defects. Babies may be physically dependent on the drugs and show withdrawal symptoms, just like with opioids. So here's the final case study. How would you move to? A couple minutes. Barbara, a middle-aged woman, is prescribed Xanax for anxiety by her primary care physician. She also takes Ambien, prescribed by her gynecologist to help her sleep. She's overweight, has adult-onset diabetes, smokes half a pack of cigarettes. When socializing, she consumes alcohol, preferring wine coolers to other beverages. So, what are the red flags here? And so what's wrong with this picture? And these are typical people. So what do you see as a problem? Potential.
Multiple doctors,
That's for sure.
gynecologist prescribing.
Multiple doctors.
Don't normally go to your gynecologist.
What else?
Just going to your gynecologist to
Get
for
Ambien.
Ambien.
You know, I mean, it's
Yeah, that's not good.
getting it anyway.
General health.
General health.
Well, her smoking, definitely. I mean, smoking and her alcohol use with the Ambien, and the Xanax.
Yeah, that's a setup for overdose right there, all those three drugs together.
Several years ago, there were studies made around smokers and who also drink excessively.
Well, smoking is a risk factor for a drug use disorder as well. So she's really set up to have a drug use disorder. And we could talk more about it, but I got a little behind. So the one thing about sedative hypnotics that you really need to know is you cannot stop taking it. It has one of the worst withdrawal death rates of any other drug, and it's a very, very long process. So if you have people who are on sedative hypnotics, they need to be cared for by a physician who knows what they're doing, because it's a very serious issue. Ideally you taper the dose and eventually stop it. However, some people just refuse to get off. And if they refuse to get off, what you try to do is you try to lower them down to the lowest dose where they can live with it and you can live with it. And switch to benzo instead of a barbiturate. Also, there's a lot of people with comorbid disorders, depression, things like that, to treat that. Here are some of the types of treatment that are available. I think it's really important to try to train counselors in motivational interventions and try to form a bond with your clients, even though you might have a hammer over their heads. But if they can trust you, then they'll be more honest. Try to figure out how to, like you've done, try to get medications and treatment that's low cost for the patient. These are the factors that affect treatment participation. Family participation is a really huge one right there. And these are the issues that affect outcomes. Treatment reduces drug use by 40 to 60% and reduces crime by 40 to 60%. Increases employment prospects, and believe it or not, alcohol and drug treatment is just as successful as treatment for diabetes, high blood pressure, you name it. Because, let's face it, behavior change is hard for all of us. If it weren't, we would all be a normal weight, we'd all exercise every day, we'd, do all of these things that are supposed to be healthy. So, change is tough, so stick with it and, help your patients. Here's one of our patients in a DWI program. He was a chronic DWI offender, drug user. This is him 2 years later. It's almost not the same person. This is a happy outcome, and I know you've had some of those, and just kind of concentrate on those. There should have been some fact sheets out there for you to pick up. I don't know.
She just brought it.
Oh, okay. You can get these also off the internet. And this is the URL to go to. Or you can go to VWU SAMHSA fact sheets. And they talk about a lot of the issues that I've talked about today. We don't really have a whole lot of time. Here is Here is where you go to do the evaluation.